Do you think life is simpler as time evolves? For some, it can be more complicated when facing issues about health, estate plans, probate, long-term care, and more. That's why Attorney-CPA Joe Cordell hosts ElderTalk with TuckerAllen, providing intelligent answers for those thinking about their future. Here's Attorney-CPA Joe Cordell.
Welcome to another episode of ElderTalk. We will continue the conversation that you have participated in at least over the last, 6 months or so, Jill, that we've been talking about health every other week, literally.
Yeah.
But we find that this is the most pressing issue in your mind. So we thought that we would focus on another healthcare provider in the St. Louis area who is kind of on the inside of this whole pandemic challenge. And they have managed to operate successfully through a circumstance where a lot of people in this industry, and we'll talk a little bit about this, have been devastated financially trying to continue to provide healthcare services at a time when there was a lockdown.
Yeah, very challenging times.
And these are guests that you've seen before, at least you've heard before. And Jill, why don't you reintroduce our guest?
Yes, we are so happy to welcome back Mark Dwyer, the CEO of the Rehabilitation Institute of St. Louis, and Ann Warren, who is the Chief Nursing Officer of the Rehabilitation Institute of St. Louis. Welcome back. First time in our new TV studio.
Thank you for having us.
Thank you very much. Appreciate it.
Welcome. So a lot's happened since you were last on. How many months ago was it, Jill?
I'm thinking 6 or 7 months.
Yeah, a lot has changed.
Mm-hmm.
So let's start out by going over again kind of the focus of the Rehab Institute. Where do most of your clients or patients come from?
Most of them come from the acute hospitals, so like Barnes-Jewish Hospital, Barnes-Jewish St. Peter's Hospital, Progress West, St. Louis University Hospital. So the acute hospitals, after they've had a stroke, brain injury, spinal cord injury, maybe an amputation, if they've been in a bad car accident, have major multiple trauma, those types of things. People that need intensive rehabilitation, we require 3 hours of therapy per day in order for them to be able to go home. Our goal is to discharge our patients home, not to a long-term care setting. And that's the reason why our level of care was created back in the 70s and 80s by Medicare, was to help people get home.
Well, are you attached to any particular hospital or hospitals?
We are an affiliation between Encompass Health. We're the largest provider of rehabilitation hospitals in the United States, and we're partnered with, here in St. Louis, BJC Healthcare. So one of our hospitals is located on the Barnes-Jewish Hospital campus down in the Central West End. And then our second location, we're the entire third floor of Barnes-Jewish St. Peter's Hospital up in St. Peter's.
And isn't a good percentage of your clients senior citizens?
Yes, a good number of them are, and that's pretty typical in a rehab hospital.
Right.
Again, especially when you're talking about stroke patients, that tends to be an elderly population. But unlike some other rehabilitation hospitals that might be, almost 40, 50% stroke patients, we're around 25%. We have a fairly high percentage of patients who are coming in with spinal cord injury and brain injuries because we sit between two level 1 trauma centers, Barnes-Jewish Hospital and St. Louis University Hospital. And so we get a lot of brain injury and spinal cord injury patient as well. And those tend to be younger patients. But of course, the stroke population is a fairly elderly population. And we also see a fair number of non-traumatic spinal cord and brain injury patients, which are usually cancer patients after tumor resection. And they can be an older population as well.
And I'm curious about something. There's been all this fear with the pandemic and a lot of folks not seeking medical help. Mm-hmm. So say you take someone that had a stroke and they're too afraid to enter a rehab hospital. They think, well, you know what, I'll just go home, take my chances. Have you seen people resistant?
Oh, yeah. Matter of fact, we're also affiliated with the Washington University School of Medicine. We have their physical medicine and rehabilitation residents in our building. So we interface a lot with them. And they did some actually very interesting research early in the pandemic out of WashU. They looked at emergency department records across the country of stroke patients and how many stroke patients were coming to the emergency room during the pandemic versus before. And they saw almost a 50% drop-off of stroke patients going to the emergency room.
Wow.
Now, it's not like the pandemic all of a sudden cured 50% of the strokes in America.
No.
It didn't happen. So that was stunning.
And that's especially troubling because apparently time is of the essence.
Yes.
Yeah.
Very much so,
If
If you don't
especially
come
with a
during a
stroke.
certain amount of time,
And
Yes.
you're not
there's
going to
a
get back
point
to
of
that level.
Yeah, and there's a point of no return
Yes.
if you don't get physical therapy, speech therapy, occupational therapy after a stroke.
You can still recover for quite a long time. Some of the research shows that you can still make progress after a stroke up to 1 or 2 years post. But you're right. A lot of those early gains are really important. And again, if you want to get home quickly versus ending up, in a long-term care setting, which, sometimes that might be the right place to go. But if the goal is to get home, then we want to
Yeah.
intervene as quickly as possible.
So now on a stroke victim, I didn't intend to go down this avenue when we talked because I was going to talk more about what rehab is and what your institute does. But I'm interested in the fact that strokes are notorious for causing problems with people's brains, or there's permanent brain injury, and that apparently that's the root of much of the inability to recover fully. So when you say that you can still make progress even after a couple of years, is that progress that's being made, is it mainly muscular, or is it still relate to neurons in the brain or brain cells?
Yeah, depending on, there's different types of recovery, but part of it's what's called neuroplasticity. It's the ability of the brain to be able to shift some functions. If that part of the brain is just literally destroyed and it can't repair itself, then other parts of the brain can sometimes take over some of the function of those. Now, that's not always the case, but that might be why you still see some long-term recovery over time. But sometimes it's just that part of the brain is healing. The swelling goes down, and you get some recovery of those parts of the brain. But sometimes it is muscular too. Sometimes we're just going to try and make the patient stronger, so that muscle might not have about 50% of the activation it did before, but it's still got 50%. But now we're just going to make that 50% stronger, so that they can stand, they can brush their teeth, they can grab the plate out of the cupboard.
So even when you're doing this physical therapy, for lack of a better word, the physical part, that is in fact stimulating their brains to be more effective.
Yes, very much so. Movement is key. So we don't want to have people just sitting around, laying around. That's why in rehab, we get them up as fast as we can. If we can get a patient up while they're in the emergency room, we will. If we're seeing them a day or two after the stroke or the hip replacement or whatever whatever may be going on, we want to get them up and moving as quickly as possible, because that stimulates the brain.
I remember that with my mom after she had her stroke, and this was several years ago, and they had her moving right away, and it was amazing, the progress. She could not even button her blouse, brush her teeth, and with that therapy, she learned how to do that all over again. And they said, the other part of her brain was taking over while the other part was healing.
Yeah.
But you do need a patient that is motivated, right?
And a lot of them aren't.
Yeah, I'm just thinking that some patients aren't prepared to do the regimen that's required. And maybe that's one of the reasons that you're in-house versus sending them home with a list of instructions.
I think in some ways, the pandemic kind of worked in our favor in that aspect. A lot of long-term care were on extreme lockdown. Nobody's coming in, no visitors at all, not even one a day, anything. And so, yes, the patient might want to go straight home, but when you've got family members there that are saying, wow, we're not going to be able to help you in and out of bed or to use the restroom, they know that they need some help. And you look at that option or the shorter option. Our average length of stay is 2 weeks, 2 to 3 weeks at most, in most cases. So it's a much more intense but shorter duration. And we still had families come in for family training. That doesn't mean that in 3 weeks we're going to get them back to their baseline where they were, but we're hoping that we get them strong enough and teach them to utilize different tools that they may need to now button that shirt or brush their teeth, and teach the family the safest way to be able to help them to get them back home and back to the community. And then they can continue with home health or, wound care or anything like that back at home instead of being, in lockdown. So
you said that your typical stay is like 2 to 3 weeks. Is that being driven in part by insurance limitations, or do you think that's sufficient time to accomplish what you want to accomplish with these
Yeah, we monitor our outcomes very, very closely, and we compare ourselves against other facilities in the area and across the nation, and our outcomes are always above the norm, and we're always seeking to keep improving those. But at the same time, we are paid a one amount for the whole length of stay, so we're not paid on a per day rate. It's one amount for the whole length of stay. So from a financial standpoint, you can't not pay attention to that. So if you keep the patient for 3 months and you're only being paid essentially for 2 weeks, that's not sustainable. So that has changed the practice pattern over the years in all healthcare settings, not just rehabilitation hospitals. But the amount of progress that we make in 2 weeks now, it's so far eclipses the progress that we made when I got into inpatient rehab back in 1987. We make so much more progress so much quicker now because the research has advanced. We know we can get people up so fast nowadays. We know we don't have to delay certain things. We can get people moving right off the bat. And so that higher level of knowledge of how the body works, how the body recovers, and that you don't want to put somebody on bed rest for 2 weeks after a stroke. That used to be common practice.
Yeah.
Oh, with heart attacks, should be a month.
Yeah. Oh, yeah. With orthopedic procedures, I mean, gosh, I remember when they used to not let a total hip patient come to us for a month. It's just, people laugh when you tell them that now. Students laugh when I tell them that. Now, the total hip patient, they go home on the day of surgery now.
Well, and that's interesting. You said that mentioned it was 1987 when you got into the field. My mother's stroke was in 89. And granted, it was a severe stroke, but they kept her 6 weeks.
Oh, yeah. Oh, yeah, that was typical back then.
Yeah.
Yes.
But now when you send them home, though, after 2 or 3 weeks, you probably are pretty insistent that they follow some sort of regimen after that. And are they coming in for some sort of follow-up? Yes. And where does that take place? At one of your facilities?
It could. They could do home health, like Ann mentioned, if they're not quite ready. If they're not quite ready to be out in the community ambulating or that type of thing, we can do home health for a while. But usually, the ultimate goal is that they finish their rehabilitation on an outpatient basis, so they can go to outpatient physical, occupational, speech therapy. And we do have an outpatient clinic at our hospital down in the Central West End. But I mean, they could go to any clinic, any outpatient clinic around if it's closer to their home or the like.
So some people may be wondering, why do hospitals not do this? In other words, why is this not just simply something that a hospital would take care of like it does other things related to their patients?
Hospitals are meant for acute. So their job is not to do that long-term therapy. They're to stabilize an acute situation, and then you go to the next level. So
is it that their business model – I tend to come at this from a business standpoint. You can tell I'm a CPA. But so I wonder, though, is their business model simply not designed for this, or is it that the facilities or the employees are not adequately equipped? How would you explain this development?
It kind of gets back to your question earlier about payment. The way that payment has changed over the decades is just like Ann said. The payment models are stratified based on what you're trying to accomplish in each setting. And for an acute hospital, like Ann was saying, where you first go, the emergency room, that type of thing, they're paid to stabilize the patient and, if possible, discharge them home if it's a fairly minor thing. But if it's more major, then they're going to need follow-on care. And so the acute hospital is meant to stabilize them, and then they can go on to, say, us if they need intensive rehabilitation. If they're going to need longer type of nursing/medical care, then they might go to a skilled nursing facility. If they still need very high level but long-term, like ICU level care, then they could go to a long-term acute care hospital. So that's why we have all these different settings in which you can go, and each one of them has a different payment model by Medicare and by the insurance companies. So that kind of drives where you go in the pathway there, depending on your needs and the like. But the acute hospital, in the United States now, the average length of stay in an acute hospital is about 3.8 days, I believe. So you can't do long-term intensive rehab like what we do in the Rehab Institute in 3.5 days.
when you'd also see a shortage of rooms, which we've seen in this pandemic. We have massive amounts of people that are having to go into the hospital for acute needs, and they're running out of rooms,
Space,
equipment, staff. that model's just not made to.
And there's
affect
such pressure on hospitals now to get people out and sit home. It's almost uncomfortable whenever you hear that a loved one is going to be out of the hospital in less than 24 hours. You're wondering, is that really the ideal thing? But insurance companies are really in a position to dictate a lot of policies within parameters, of course. And while I don't have a lot of good things to say about personal injury lawyers, medical malpractice lawyers, I would say that they do have healthcare providers looking over their shoulders, and
Right.
maybe that's not too bad a thing. But tell me then, when we're looking at this Affordable Care Act, and apparently there will be efforts with this administration, the Biden administration, to see that implemented more fully. Do you expect over the next 3 to 4 years to see your practices and your policies being affected by this phenomenon, or will it not touch your field?
I don't anticipate anything with the ACA would change that. Part of the ACA, though, is looking at new models of care. So, depending on if there's a good example is one of the things that was experimented with over the last 10 years have been bundled payments, which is just a different way to create one payment stream for multiple levels of care, say the acute hospital and then a rehab hospital, then say home health, where you get one payment for all three and you divide it up. So that's very different than the way it normally works. So dependent upon if they go down that path and start trying to look at new innovative ways to create new payment models, that could change things a little bit. But outside of that, I think the ACA impact that we're waiting to see what the impact of in Missouri is going to be the expansion of the Medicaid program. That the voters approved that last year,
Right.
and then we just saw some activity in the legislature last week where there won't be funding for that. So there's going to be some wrangling over that.
Yeah, funding's going to have to come from somewhere.
Yeah.
Exactly. And we see that there's still a lot of, especially where one of our hospitals is located in near downtown. There's a fair amount of need down there for people that don't always have the ability to pay for healthcare, and so having access to Medicaid could be a lifesaver, literally, for them.
Now, what portion of your patients now, ballpark, would be Medicaid?
17%.
17%. So
That's it? 17%? Okay.
I'm surprised. That's a pretty low percentage.
I thought it would be higher.
Yeah, depending on where you're at and where you're located, 17 to 20% is probably what hospitals will see. Now, if you're more in the suburbs, it's usually going to be a little bit lower than that.
And then assume a substantial part is paid through Medicare, right?
Yes.
And
Yes.
Medicare, I know, pays for rehab as
Yes.
opposed to custodial care, et cetera, like
Yes.
skilled care facilities
Yes.
sometimes. So what percent would be Medicare related?
Well, we actually break it down across two parts of Medicare, because there's old Medicare or what I call pure Medicare, and then there's Medicare Advantage, when people opt out of Medicare and go on one of the Medicare HMOs. So right now, about 39% of our patients are what I call pure Medicare, and then what is it, Ann? Around 18-20% of our patients are Medicare Advantage. So 55 to 60% of our patients.
That's what I would
Medicare.
expect,
Yeah.
because rehab. When you think of rehab, you think about broken bones and often broken hips. This tends to come to mind. But strokes apparently are.
Yeah.
So what are, if you were listing the top 3 or 4 categories of need that come to you, what are they?
It's the big three: stroke,
Big
brain
three.
injury, and spinal cord injury. In a rehab hospital, those are usually what we call the big three: stroke patients, brain injury patients, and spinal cord injury.
Now tell me, brain injury, how is that typically happening?
Could be a car accident, a fall. There's numerous ways that it could happen.
But those are
Gunshot
probably
wound,
younger
anything like
people,
that.
right? Not
Well,
Medicare
you'd be
as
surprised,
much.
when if an elderly person falls, it's not just their hip they're hitting. Sometimes it's their head
Their
they're
head,
hitting.
sure.
So, like Ann said,
Getting up on a ladder when they perhaps shouldn't.
Yeah.
you know?
Yeah.
Yeah, you'd be surprised. But again, a fair amount of ours, almost 10% of our patients are oncology related. So those are usually tumor resections. So that's like a brain tumor. So that's a brain injury. It essentially does the same thing to the brain as a good whack upside the head, or a spinal tumor that's removed. That can mimic a spinal cord injury. So a fair number of our patients are what we call non-traumatic brain injury, because it wasn't a car accident or something like that. It was actually surgery to remove something.
And how challenging has it been treating patients during the pandemic? Because it's not as if a physical therapist can, have social distancing with that patient they're helping walk again.
A lot of protocols.
I was going to say,
I
Chief
can
Nursing
only
Officer
imagine.
can tell you all about that.
How does that work?
Lots and lots of protocols right from the beginning. I would say, what did we start off with? 3 or 4 meetings a day discussing protocols.
7 days a week.
Yeah, in the morning, in the afternoon.
Saturday, Sunday.
Yeah.
And you all can't do this by Zoom in your business. There's a physical presence required for your patient.
We ended up doing it all by Zoom.
Well, the meetings, but the actual physical therapy.
Right.
That's difficult.
So there was a lot of staff concern, and so we had to be really, really diligent about the protocols that we put in place for temperature monitoring and making sure that everybody was compliant with their personal protective, equipment, and doing rounds to ensure that everybody was social distancing when they could. It's been extremely challenging to our therapy department to not be able to do group therapy. So there's a lot of one-on-one therapy, but there was a lot of group therapy that would happen also,
Right.
and we've really been limited with that. And so different areas that perhaps were not therapy areas have now, this room is now a therapy room. And so now we have a bunch of small gyms within the hospital, and just being really resilient and thinking outside the box and coming up with new areas and new ways to accomplish the same thing, because, it's really not an option. Nobody plans to have a stroke. Nobody plans to, get in a car accident. And
So what was your occupancy higher or lower during this period of time?
It was actually higher. Like Ann said a little while ago, some of the long-term care facilities were not able to take patients and the like throughout a good part of the year. So we saw more patients being directed towards us because we were still able to take them. So for the last 7 months of the year, we actually had very high census. Matter of fact, we broke a record in October with the highest 1-month census we've ever had in our history at the Rehab Institute. So it was busy. You mentioned a minute ago some of the challenges, and one of the ones that nobody really thought of going into this with social distancing is no hospital was designed with social distancing in mind. If you walk onto an average nursing unit, everybody's crammed in there.
Right.
Well, you can't do that if you got to have 6 feet. Break rooms, all those things, staff offices and the like, those are all usually pretty tight. We weren't able to see the same number of patients in our therapy gyms because we had to maintain distancing between. So that was a huge challenge, just figuring out how do we still squeeze everybody in here, but keep them 6 feet apart when the buildings, and it wasn't just us. Everybody, all my counterparts I was talking to around the city were all like, none of our buildings were designed to do this, but we had to figure it out. So spaces got converted, but you figure it out. That's what you do.
Have to be creative.
So at BJC, though, you were attached to a larger facility. Was that helpful?
It was definitely helpful from the standpoint that, being a joint venture between Encompass Health and BJC. Encompass Health, we have hospitals all across the country. So we were kind of learning from all over the country, and our COVID task force could take all that information and then provide it to us. But also being attached to BJC, we had access to their incident command, all of their expertise. WashU, Washington University School of Medicine is essentially the medical staff for Barnes-Jewish Hospital. So
really,
oh yeah. So we were able to talk with like Dr. Babcock. She's a preeminent infectious disease physician, nationwide, if not worldwide. So we were able to call her on the phone and have a question answered. our medical director reached out to her numerous times.
And I knew that the medical school, supplied doctors and residents and whatnot to BJC, but so you're the beneficiary of that as well.
We do have WashU physicians in our building. They're the faculty for the physical medicine and rehabilitation residents in our building, yes. Not all of our medical staff is WashU, but half of it is, yes.
What about speech therapy? How do you provide that wearing a mask?
The speech therapist is going to be masked and they're going to be face shielded. So we still require face shields and or goggles whenever we're interacting with a patient, even now. So the speech therapist, it was even more important that they make sure they are fully protected. And for some of our patients during certain speech procedures, we went even further than that and had them wear gowns and gloves. But yeah, you're right. For some of those procedures, you can't have a mask on the patient.
They have to take off their mask, I would imagine.
Right. And speech therapists work a lot with feeding and swallowing and that type of thing.
Right.
So yeah, you can't have a mask on during that.
So on swallowing, et cetera, were your facilities also getting people who had the virus, they had gone into the hospital, they had been intubated, and they had been on this ventilator for some period of time, which I'm told that for every day you're on a ventilator, you require like 2 or 3 days of rehab. And so you had people in your facility then who were recovering from the virus and a ventilator.
Absolutely.
Yes.
Yeah.
Yeah, we call them, they're actually called COVID-recovered patients at that point. The criteria has changed as we've learned more about the virus over the past year. But generally speaking, now you're considered to be COVID-recovered after 10 days. In certain conditions with real severe cases, it might be 20 days.
If you needed oxygen.
Yeah.
Right.
And you saw, though, a high recovery rate when people came off the ventilator. The real risk was whether they would survive on the ventilator,
Yes.
I guess.
Yeah. If they made it past that, then they stood a good chance of recovering. Nationwide, in all 138 of our hospitals around the country, we have gotten over 80% of the patients home that have come to us as COVID recovered. Yes.
Wow.
So those patients that required like the speech therapy or maybe patients that came with a trach, anything that would be aerosolizing, they would be in private rooms. There would be different PPE protocols for them. So the gowns, the gloves, whereas you may not need that. You may just need the mask. Certain patients, it needed to be an N95, not a surgical mask. So there were different protocols for each diagnosis, really.
Did you have any staff that were just so fearful, especially at the beginning of the pandemic when we just didn't know what we were dealing with, that just said, hey, I'm resigning. I don't want to take this chance?
Yes.
That leave AMA or?
Well, they made personal choices, and depending, and we don't always know what's going on within their lives. If they have a family member that they're caring for who might be immunocompromised, the last thing they want to do is bring this disease home. And like you said, early on, we really didn't have a full picture of what we were dealing with.
Right.
This has evolved over time. I was talking to one of the Washington University internal medicine physicians early on, and he said, we just don't know what we don't know yet. He said, in a year, we're probably going to know everything there is to know about this virus. But right now, we just don't know everything.
And then you add the PPE shortage.
Yeah.
There was mask
and there was a lot of
shortage.
fear.
That was everywhere.
There was a lot of fear.
Not just here in the U.S. It was everywhere. Nobody could get the things that they needed. And that was really scary for a lot of staff. And I would say that's probably been one of the bigger challenges this whole time. There's, for years, been a nursing shortage. And now we've got an even bigger nursing shortage. The schools were shut down for some time. So
how did you solve the situation where you have this elevated census or occupancy and this reduction or reluctance on the part of employees to come in? And I think this happened across America, but maybe more in the health field than otherwise. Were you able to meet your staffing needs during this period of time? Apparently so.
Yeah, I mean, for the staff that didn't leave, I mean, hats off to them. They did an amazing job. We keep seeing in the news and the like, heroes, our healthcare heroes, and I'm not one to throw around the hero word very much, but it really does apply this year. I mean, our physicians, our nurses, therapists, housekeepers, everybody. I mean, the sense of mission and caring for their patients, their community was just incredible this past year. And so to meet those needs, I mean, we had nurses working extra shifts and
So
working
really, their
overtime.
families also heroes. A lot of time away from home.
Yeah,
for sure.
I can imagine.
And even had some staff members early on that stayed.
Yeah,
away
I
from
can
home,
see that.
That went and stayed
Reluctant
elsewhere
to go home.
because
we
they were
didn't know
afraid to
enough
bring it
back then
home.
either. Yeah,
They just stayed at, say, a hotel or?
Yeah.
Yeah.
I know. I saw some news stories of people living in a camper in their driveway. They wouldn't go in their house.
Wow.
They were on the property, but they wouldn't go in the house. The family and the kids were in the house, and they kind of wave at each other through the windows. But
Especially early on. I mean, I didn't go stay anywhere else, but certainly in the beginning, that all the clothes came off downstairs, and I went and took a shower and the hall, bath and all of that before I would interact with anybody in the house at all, because you just didn't know. And then, like I said, with the shortages and
So how many
didn't know.
patients can you accommodate at one time in your facilities?
we have 131 beds total. We have 96 beds at our Central West End, and then 35 beds at our St. Peter's Hospital. So 131 total is possible.
So do you generally see a lot more demand for the space or the beds closer in to BJC or further out St. Peter's?
Both. I mean, both of them have been very full, like I said, the last 7-8 months of the year. Matter of fact, at our St. Peter's location, we're looking to expand that and expand that unit to 40 beds. Matter of fact, we just talked to BJC about that today and agreed on that. So we'll be embarking on that project here pretty soon. And we're getting ready to open a 40-bed rehab hospital in Shiloh, Illinois with BJC as well because of the need. But yeah, last year, St. Peter's, our 35-bed hospital out there, was full, almost 60 days out of the year. And then it was nearly full at 34 beds, another 60 days. So that you can imagine that makes it difficult for us to bring patients in if you're full. As a hospital, you never want to be completely full because then there's patients you can't help.
Right.
No
That need you. So you want to. That's why you're always trying to manage your beds so that you're not completely full. And that's why we want to do the bed expansion out at St. Peter's, is so that that doesn't happen again, and we can better serve the community.
We're hearing more and more about the variants to the virus surfacing. Is that creating a lot of concern with your facilities?
Not so much. I mean, the virus is the virus, and we don't know when we're dealing with a variant or when we're not, really, at this point. Testing may get to the point at some in the future where we know exactly which variant is which, but the reality is viruses mutate all the time.
Sure.
The flu virus is a different one every year, so this is just something we're going to have to deal with on an ongoing basis with COVID.
And at least at this point, I mean, as Mark said, we're still wearing the PPE. We're very fortunate. Our hospital was one of the first within our company to be able to have the in-house testing. So, we can get results back in 15 to 20 minutes, and that helps.
Yeah.
Right away.
Yeah.
So even if somebody is not symptomatic.
In the technology of developing this messenger RNA, apparently the method of developing the Pfizer as well as the Moderna.
Yeah, both of them. Mm-hmm.
Yeah, and that the CEO was talking the other day, and Wall Street Journal reported this, and he was saying of Pfizer that we're in the process of developing vaccines now for a lot of viruses and a lot of pathogens.
Yeah.
And his point was, he said that what has happened over the last 1 year is that we've moved forward a decade.
Oh, yeah.
He said we're a decade ahead of where we thought we'd be in our capacity to develop vaccines for immunity. And it's almost like the Manhattan Project, where you pour a bunch of resources, just a pile of money and your best brains on a subject, and you do something in a period of a year or 18 months or so that you wouldn't have thought possible. And apparently that's what's happened with this.
Yeah. It's actually a female physician, I can't remember her name, who pioneered the messenger RNA technology. And it's been around a while. It's just taken a while for it to really take off. And this application, since we had to move so fast to create a vaccine for the COVID virus, this was what was latched onto. And you're right. They're saying that this is going to literally revolutionize medicine with infectious disease. As a matter of fact, that particular physician, she now, I saw an interview with her just a few weeks ago where she said, now I'm going to see how this works on cancer. Her goal is to use this for cancer. Yeah, I mean, you're right.
Wow.
They're looking at this
something.
as not evolutionary, but revolutionary. And we may be able not just to go after viruses and bacteria, but cancer cells with this. And this could be huge. I've seen some people ask, was there any good that came out of all of this? And I mean, the incredible tragedy of 550,000 people dying from this is just unimaginable. I mean, gosh, a year ago, could any of us imagine that 500,000 people would have died from this? But I mean, if there's anything positive that could possibly come out of this, it might be that the future of medicine could be
Has changed.
totally different.
Yeah.
Evolved
Yeah.
in such a short period of time.
Yeah, and this is the infancy of this technology. I mean, this is like the Model T version of this. Can you imagine where this might go?
And I think there are a lot of things that are positive. Perhaps they don't outweigh what's on the other side of the scale, but we should be grateful at least for these things that have developed. And among them is telemedicine and the using Zoom, and to what extent do we need to travel for meetings? We've taken, as you indicated, technology that pre-existed, but we just were slow adapting and adopting.
We all got crash courses.
Yeah, that's right.
We
In
certainly
virtual
did.
meetings, for sure.
Total necessity.
Teams, Zoom, WebEx, all in one day sometimes.
And so I think everyone agrees we're not going to snap back to exactly where we were.
Horses out of the barn.
But we will, a lot of this will stay. And we don't know to what extent people will be going to business meetings. Some of that will happen by plane. But I think a lot of our lives are forever changed. And in many ways toward being more efficient. Using
Maybe a lot of companies that don't bring back all of their employees to working in the building. I mean, some companies
That's
have
what
found, we've certainly
anticipate
found
happening.
on some levels that our liaisons had their best day, best month of the year, and weren't able to be, in the hospital. So I think that not everyone can do that, but some people can work better and more efficiently from home.
Yeah.
And I think that you're going to have a lot of companies that are going to look at that and why pay for that big building and the upkeep and everything that comes with that if you can get the same thing by having those people work from
Probably
home.
not a good time to be in commercial real estate.
No.
Yeah, it could be tricky. I don't know if this, the articles that came out a while back said it was going to be permanent. I don't know if it'll change, but Ascension Health, who has their headquarters here in St. Louis, I think 1,500 employees, of course, they're all working from home, and they said that that's going to be permanent.
Wow.
So that's a huge change. And Google, Twitter, I think Twitter now has allowed all of their employees to work remotely if they want to, anywhere in the country. So you don't even have to be in the city anymore. You can be anywhere you want.
Whole different meaning for work-life balance.
And I think what we'll be groping for are what are the outer edges of when that's good and when it's not.
Sure, exactly.
And some businesses, are very collaborative by nature. And you take people and you spread them across a continent, and even with Zoom, they're not quite as effective. So I think that there will be an effort to discover what those parameters need to be. But one thing about it, it'll definitely not be the way it was.
No.
And you mentioned a while ago that, Mark, that you said we, and you referred to a national organization. Was it Compass?
Oh, Encompass Health, yes.
Yeah. So explain St. Louis Rehab's relationship with Compass Health.
So the Rehabilitation Institute of St. Louis, we are a joint venture between Encompass Health and BJC Healthcare. So the Encompass Health side, our home office is in Birmingham, Alabama. We operate right now we operate 138 rehabilitation hospitals in 40 states around the country. Actually, 2 in Puerto Rico as well. And we're quickly expanding. Matter of fact, we're going to be adding 20 more hospitals by the end of 2022. So we'll be almost 160 hospitals by then. We also offer home health services in some of our markets, not all of our markets. I think now we're about the 4th or 5th largest home health provider to the Medicare population in the country.
Do you offer home health in St. Louis?
No, with our partner here being BJC Healthcare, they have a very large home health operation, and so that we really don't need to bring it here because our partner already has it. We'll bring it into markets where we have hospitals that are lacking in home health coverage, and that could benefit from it.
So is that the nature of ownership nationally of your hospitals, that you have a joint venture with a local facility? We're
seeing more and more of those. Matter of fact, most of our new hospitals are joint ventures. I think right now, it's around 50 or so of our hospitals are joint ventures. I know the one here in St. Louis was one of our early ones. So the rest of our hospitals are wholly owned by Encompass Health. But again, most of our new ones are joint ventures with acute hospital systems.
So do you get patients that are coming from other hospitals and not BJC?
Sure.
Even other states.
Yeah.
And your relationship with BJC doesn't impact or impair that in any way?
No.
So what percent of your patients do you think come through BJC? I assume the substantial majority.
Yeah, the majority of them do. It's over 70% come from BJC. But, we get some patients from other hospital systems. We get some from long-term care facilities.
We get some from home.
We get some from home, usually amputee patients and the like, who need that prosthetic training after they get their final prosthesis. Some of the outlying hospitals. So it comes from a lot of different places.
Rural areas.
Yeah.
And you said from other states, how far away?
Miami.
Right now we have a
Really?
patient coming from Miami, but that's usually somebody who lives in St. Louis or has family in St. Louis. Like this example, if you travel out of town and you visit family and you get hurt, you might not want to do all of your rehab down there. You want to get back home, be closer to your primary family.
Gotcha.
That type of thing, or maybe the mom or the grandma lives alone, 2 states away, but the kids are here in St. Louis, so they want mom to be here to do the rehab, so they can help, and maybe the mom's going to come live with the kids when she finishes rehab, and maybe eventually, go home to her state 2 states away. But so we see some of that. But
Now that the numbers are declining, do you think there's more of a sense of calm within your facilities among your staff and the patients?
Yes. I think that contributes to it. I think that communication contributes to that. We learned very early on that communication was key for families, for patients, for our staff. Even if we didn't have the answer right then, they wanted to hear from us that we don't have the answer yet, but this is what we're doing, or this is where we're in the process for it. Again, I think it went back to the huge shortage of protective equipment, and you've seen on the news and the newspaper, there was this huge distrust of administration and you're sending us out here, you're changing the rules.
Well, I don't think we've seen this much fear since, say, the 80s with AIDS.
Yeah. When I got out of PT school in 1987, that was right in the height of the AIDS crisis. And I remember going to treat a patient and people, colleagues telling me, I'm not going in there. And it was that level of fear. But again, it was fear of the unknown. We just didn't know enough about it yet. And that was the early days of this. And like Ann said, the communication was so important. And now I think part of the calm now is definitely the vaccine being out there and more and more people getting that.
That's huge.
But also the protocols have stabilized. early on, gosh, Ann, sometimes we were changing the protocol same day. We'd say one thing in the morning, and then we come to our staff in the afternoon and say, we learned something new, and we're going to change this. And I mean, their heads were just whipsawing around. They're like, wait a minute, you just told us it was this. And that's frustrating, and we definitely understood that. But as we're learning this information, we want to get it in play as quickly as possible. But all of that has slowed down. We've learned more about the viruses. We know how they're transmitted now. The protocols have been fairly stable over the last few months, and we're not having to change them.
There's no shortage.
Yeah, we've got
for that.
stockpiles of equipment now. Gosh, we used to keep about 1,500 surgical masks on hand at any time before the pandemic. Now we have over 80,000.
I mean, at first, I moved my office.
Yeah, upstairs.
I'm going to be upstairs on the floor. It just made more sense. I was more readily available for staff and for patients, and being one of the clinical parts to the leadership team. I also, at that point was like, well, I am going into patients' rooms, and if you guys are not, I don't want to be, coming back down and possibly, spreading something to you either. So, that communication was key, and them seeing us up on the floors and that we were there for them. Encompass also, stepped up, and we had some people that were afraid at first, and when they chose to stay at home, we, for a period of time, did not penalize them with attendance or any kind of disciplinary. Everybody was just kind of rolling with it and trying to adjust. But again, back to AIDS and that fear, I lost a lot of really good seasoned nurses in the beginning because they were terrified, and they were, maybe 4 or 5 years away from retirement, and it was like, ooh, hey, I did not come this close to do this. I'm gonna take a partial retirement.
And they were being told they were in the most dangerous age cohort too. As you get older, you were more susceptible to it, so that factored in too. Yeah.
And they may have had family members who would be vulnerable. And
Exactly.
So I'm surprised that among the things that you didn't mention as being on that list would be things like a fractured hip, et cetera. Tell me how that's typically handled when you have an older population that has these orthopedic injuries. That calls for rehab, right?
It can, yes. So a fractured hip can have different courses of treatment. So if they require a total hip replacement, those patients typically don't come to a hospital like ours because they don't need that intensive rehabilitation. Like I said, a lot of those patients now, they're going home same day. And or they might need a few days in the hospital. But the goal of most acute hospitals is to be able to discharge those patients home within 1 to 2, maybe 3 days of the surgery. So you don't see too many of them. But the patients who have a hip fracture that for whatever reason they don't do a hip replacement, they might do a hip pinning or something like that. Yes, those are patients that are going to have a longer course of rehabilitation. And so we do get those patients who come to our hospital.
You may have knee replacements and things like that go straight home.
I know.
My mother-in-law went home, and they came to her.
But it used to be, even just 15, 20 years ago, 30 to 50% of inpatient rehab hospital census was orthopedic, total hip, total knee, and the like. But that's almost completely gone away.
So I'm imagining, though, that there is this substantial population of people who are over 75 who fall and fracture something. And maybe it's because they have osteopenia or osteoporosis. Is a large number of those people perhaps at the completion of their hospital stay, quote unquote, that's covered? Are some of those going instead to skilled care facilities, nursing homes, quote unquote, versus your facility? Is that where this population is more likely to end up?
It could be.
Not necessarily. A lot of it depends on if how much they can tolerate. If they can tolerate the 3 hours of intensive therapy, then they're probably more likely to end up in a hospital like ours. But
we know statistically they don't. Right.
What do you mean if they can tolerate? Are you saying if they're in intense pain and it's just too difficult for them to participate in therapy?
Yes, or sometimes you have other comorbidities that come along with that, and they're just not able to participate, whether it's a respiratory issue or fatigue, pain management, just something that is a barrier to them being able to do that intensive therapy. You don't have those same guidelines when you would go to a long-term care for that therapy. There's a little bit more leeway, and payer sources are also going to expect that you are able to make a certain
progress.
You know,
You got to make
Right.
progress.
Well, and it depends too on what the ultimate discharge status of the patient is. You know, if they fell and maybe it's because of another medical issue, and maybe that medical issue is out of control, so they might need more medical support, not necessarily rehab support at that point. That might be somebody who goes to a skilled nursing facility because that's more targeted towards managing that long-term medical/nursing need. So that may be more of the issue. The fracture was secondary. Or let's say that they fall and maybe this is their third or fourth or fifth fall. And at that point, the patient and the family say, you know what,
You're not
Mom,
safe to be
Dad,
home.
Grandma, Grandpa, you're really not safe to be at home anymore. And so the plan isn't to return home. The plan is to then go to a long-term care facility.
Where they can be kept safe.
Right. They can be kept safe and cared for. And so if a patient's not going home, that they generally won't come to us. Not always, but generally speaking, we're looked at as the place that gets people home. So if we know right off the bat they're not going home, then we generally don't bring those patients to an inpatient rehab hospital.
And to clarify that phrase, not going home, what we really mean is there's not going to be a full restoration of this person. I mean, and realistically, like I think that many people regard a nursing home as a place where someone goes that they're not expected to improve a lot. And perhaps the goal is more custodial, more supportive, more ongoing care, but less on rehabilitation. Is that fair to say?
Yes. Yeah, at that point, they need to be in a safe environment where they need a little more support from a nursing perspective and just general assistance.
Round the clock care.
Right.
medication management.
Right.
those
What
kind of
percent
things.
of your patients are over 65?
Over 65, it's around 45% or so.
Okay.
Yeah. We're a little unusual because of the trauma patients, the number of trauma patients we get. Most rehab hospitals are going to be around 60 to 70% of their patients are going to be 65 or older. We skew a little bit younger because of where, at least where our Central West End location sits between those two level 1 trauma centers. Our St. Peter's location has more, I think we're more around 50 to 55% out there. It's more suburban. We don't have as much trauma there. It's kind of a quote unquote typical rehab hospital.
So you have you mentioned your top 3. So there's strokes, there's brain
Spinal
injuries,
cord
traumas, and then the spinal. What is that when you talk about spinal injuries? What's the most
that
common
could be
scenario?
somebody that has had an accident or a fall again, gunshot wound. It could be maybe a tumor, anything that's damaged the spinal cord, and now maybe they're a quadriplegic and they're coming to us to learn a new normal. So not everybody gets back to that baseline, no matter what the diagnosis is. Our job is to teach them how
Right.
to
work
live
what
a
they
new
have.
normal.
Right.
And
Yeah.
I can see how what you would do in that case would be marvelously helpful, even essential. But I'm just wondering, how far can you get in 3 weeks with
You'd be
someone?
surprised. I love it. I love seeing people come in on a stretcher and they walk out. I love it when a lot of our patients tend to leave in the afternoon, and sometimes when I'm leaving, they're out there too, and I pass right by them. And I love stopping to talk to them when they're getting in the car because their faces are usually lit up, and a lot of them, they came into the hospital thinking, well, I'm never going to walk again.
Right.
I'm not going to be able to recover from this stroke. I'm never going to be able to, pick up my grandchild again or whatever. And here they are getting into a car to go home. But yeah, the amount of progress we've made in the 34 years that I've been in this profession is just stunning. Like you said, we used to keep people for 6 weeks in the acute hospital or in the acute rehab hospital, and now we're keeping them 2 weeks. But we're achieving double what we did back then.
And I don't doubt that. And I can see that's clearly the most important phase is that intensive, 3-week period or so. But it would be. I guess I would think it'd be wonderful if it were my father or my brother if I knew that you all had a home care extension so that when they go home, they're still in the care of a single plan.
Well, we that's where case management comes in. Mm-hmm. So even though we're partnered and BJC is the, a home care, preferred home care, but at that point, let's be real clear that maybe you have somebody that works for Mercy, home care or
their insurance company requires they go to a certain home health agency.
So that's always up to the patient's choice with that. But that's where our case management comes in, and that's probably the other big key to the whole conversation of, my gosh, everybody gets home so quickly now. It's making sure that they have all the tools they need to be successful and not end up back. And sometimes that's equipment. Sometimes that is transportation, medication management. Sometimes for a part of our population that doesn't have a payer source, ensuring that we connect them with the right resources, that they're going to be able to get their medication, that a nurse is going to come by and help them with that wound. All of those things are important. So we have
who
to make
coordinates
sure it's safe.
that?
That's the case manager. So like Ann said, they play such an incredible role because the highest anxiety point for our patients is going home. Think about it. You had a major stroke or spinal cord injury or whatever, and such that you landed in our hospital, which means you didn't have a mild stroke. You didn't have a mild brain injury or something. You had a bad one. And so they're thinking, am I really going to be able to go home? Am I going to succeed? If I don't succeed at home, am I going to, end up in a long-term care facility? All this is going through their heads.
That's probably their fear.
Right. And it's not just going through the patient's mind. It's going through the family's mind, too.
Right.
Because now they're thinking, oh, my gosh, now I got to change my whole life. I'm going to have to help, mom or dad. And so everybody's lives gets changed with this. So our case managers are there to help them make that transition from the hospital to home and for it to be successful.
So this is your employee, this case manager.
Yes.
And they will continue to be involved even if they're in the care perhaps for home health through another agency.
When someone discharges, we've already set up if they need home health, if they need wound care, transportation. We've already set up their next appointment with their primary care provider. For some of the patients, if they're going to an outpatient setting or a clinic setting, we've set those appointments up. There's communication between, a discharge summary that is then given to that next level of care or that next primary provider.
So if a patient goes through your program and they reach all of their goals, but they're not restored to what they were before the stroke, but later on down the road, their, say, neurologist feels that there could be more improvement, they're doing better, then the neurologist could recommend, prescribe more physical therapy?
Oh, yeah.
And do they go back into one of your facilities, or is that usually an outpatient?
It would be an outpatient at that point. Yeah, okay. They wouldn't be going, generally speaking, they wouldn't come back into an inpatient. But the only exception to that are patients who have had a new amputation. So like maybe say a diabetic patient who has to have a lower extremity amputation. There's different phases that they go through there. And once they get their final prosthesis, they might come back into our hospital for about a week to do intensive gait training with their final new leg. But that's kind of the exception. Most patients, stroke patients and all the others, once
Sometimes
they leave,
with the quads.
Yeah, the quadriplegic patients, if they have a decrease in function over time, we might get them back in for a week of tune-up, if you want to call it that.
Sure.
But most of them are going to continue their therapy on an outpatient basis.
So where do amputations fall in terms of the frequency that you treat them?
They're about 7 or 8% of our patient population, somewhere in that range. So, not a huge group, but a fairly significant and steady group.
That would be a lot of type 2 diabetes, for example?
Quite a few, yes.
We also have transplant patients
Yes. Mm-hmm.
that come to us after their transplant, and they're there for deconditioning and for us to monitor those labs. And
Yeah.
So is it, given the seriousness of the recoveries that you're describing, I assume you wouldn't have a lot of people who would fail to cooperate sufficient to allow the insurance to continue to pay. I know that this was a situation with my dad who had problems. He was in Florida. And in order for him to stay in this facility and continue to get care, he had to cooperate because those were the rules. You had to get better.
Mm-hmm.
And otherwise,
how'd that go?
well, he was indifferent. He didn't
Right.
really care. And I think they finally were just very permissive. But I think if the rules had been technically enforced, the rules of the insurer, they probably would have cut off the insurance. But they were pretty tolerant of him. But I know that's something you must brush up against if you
I
have
think you have
patients.
to be really creative
Yeah.
as a team, because remember, a good portion of our patients are brain injury patients. So they're not quite thinking
Clearly.
Yeah,
Yeah.
to their former. So we have to get creative. And again, that's where case management, sometimes there are times when the insurance, is like, that's it, they're not making enough progress. And that's when case management steps in. Sometimes the physician does that and I guess argues that point to get more days. I know we always have like the expected graduation day up on the whiteboard, and sometimes it can go either way. The family's like, "Oh, I'm already leaving on the 10th," or sometimes it's that long, and I'm like, "Don't get stuck on that number, because really it's gonna." Sometimes we're able to really move things along fastly, and people are ready to go home earlier, and sometimes it may take a little bit more time. And
Well, another piece to your question there, we've been talking a lot about the physical rehabilitation of these patients and their physical state, but we have to also keep in mind their psychological state.
Right.
I mean, think about it. You're newly retired, you're getting ready to travel and do a bunch of fun stuff, and you have a major stroke. So, and they land in our hospital on average 4 days after their stroke. So they're still trying to get their head around what the
They're in
heck happened
shock.
to me. They might be having some depression issues. So we have rehab counselors that work with these patients.
That's
So
what I was
sometimes
wondering, if
it's
you
not
brought
that they're
in
motivated.
therapists.
It's just that they're still grieving. They're still grieving right now. And we really, one of our corporate values is to show empathy, because we have to understand what these people are going through. I mean, driving to work and you get in a bad car accident and now you wake up in the hospital and you're told you're paralyzed from the waist down. What? So, we're dealing with some of those issues. We also have neuropsychologists that can come into our building and help patients through that. So sometimes it might not be that they're uncooperative. It may just be that they're still just in the grieving stage. And part of what we're trying to do is, at the same time we're rehabbing them, help them get over that psychological hump so that they can see that there is a light at the end of the tunnel. And we're going to help you get there.
Yeah, because like you said, they're grieving over themselves with the loss of their former self.
Yeah.
And having
And
to
their families.
create a new life.
Yeah, and the families too. I mean, the
Yeah.
families go through this. We always say in a rehab hospital that we're not just rehabbing the patient, we're rehabbing the family too. And I've been through it with my family, and many of us have with older parents or grandparents, and it's not just the patient who's suffering.
then you had the pandemic that really
all on top
cut
of it.
back
Yeah.
visitors being able to come in, and family being able to check on their loved one, physically. That just elevated the stress that much more.
What did you do with that? Did you have Zoom calls or phone calls?
We did. We
Bought a
had
lot of iPads.
Yeah, I bet.
Yeah.
a lot of iPads to do Zoom calls. We got together as a leadership team, the nursing leadership, the therapy leadership, and case management and kind of divided and conquered that each of us would take so many phone calls and emails to new admissions and then make sure that they had everyone's contact information and really giving them as much information as we could and then doing it again a few days later with someone else, because the other thing to remember is they're being told all this information, and like we just said, they're in shock. Nobody expects that.
And another thing you do, I imagine, is do you have people who essentially are the advocate for the patient regarding getting financial coverage from whatever source that's going to be more often, I assume?
Yes, that's our admissions department.
Medicare.
Yes, they'll help with with any insurance issues. If we have to get pre-authorization, they take care of all of that. If the insurance company denies it, then we can appeal it and try and get it approved through the appeal process. So, yeah, we take care of all that. Yeah, so that the patient doesn't. Patients have enough on their plate; they don't need to worry about that. And plus, the system is so complicated; it would be almost impossible for a patient to navigate. So we do that for them.
Well, we've covered a lot of territory. Time flies when we have you guys on. This is
a lot of fun.
Last time we spilled over too. The nice thing about this format, now that we're not doing this on radio, is that we have the ability to control the length. Mm-hmm. So it makes it good that whenever we're interested in a topic, we think our listeners are interested, then we just roll. So, no, y'all are great guests. Rehab Institute of St. Louis.
20 years this year.
Oh, that's right.
20
It's our
years.
20-year anniversary.
Congratulations.
Yeah, thank you.
Well,
Thank you.
It's a great place, but I'm sure no one wants to have to use it. But in the event that we need it, who knows? It's marvelous. And also having you guys on help us get an overview of kind of the healthcare situation in our area generally. So you all are a marvelous resource when it comes to healthcare. So anyway, we look forward to having you on again. This has been another episode of ElderTalk. Till next time, take care.
You've been listening to ElderTalk with TuckerAllen, providing intelligent answers for those thinking about their future, with Attorney-CPA Joe Cordell. Sponsored by TuckerAllen, your estate and elder law advisors. For more information, visit TuckerAllen.com. Listen again next Saturday for another edition of ElderTalk with TuckerAllen. The choice of a lawyer is an important decision and should not be based solely on advertisements.